Hi, this is Fernando Gomez Sancha, and this is another real-life case of a HoLEP procedure. But this time, this is a patient who is anticoagulated. I think he was having a leakage, and we, of course, stopped it before the operation, as we always try to do. And this is to show how in this kind of patients, we are a little bit more careful in performing the enucleation and in trying to get a little bit, more thorough hemostasis if we can. In these patients, despite the, occasional reports that we hear from colleagues saying I did this under full anticoagulation, my recommendation is to be careful, because bleeding from the prostate or the prostatic fossa in a fully anticoagulated patient can be problematic. So we try to estimate the risk and try to see what is more risky, if keeping the patient a little bit short in anticoagulation treatment, or the bleeding itself. So the only case where I think there is a significant risk of complications is the metallic valve patients, and there, of course, we try to coagulate as good as we can. We try to ensure hemostasis as good as we can, and we have an obligation to restart the anticoagulation with warfarin very, very fast. But of course, we have to always, be the remind, if I have to say it like this, to our, internists and anesthetists and intensivists and cardiologists, the risk of bleeding. And so we try to tailor, let's say, the treatment so that patients are a little bit in the short side of anticoagulation to try to prevent bleeding. In this case, this man had atrial fibrillation. So we used low molecular weight heparin, and we sent him home on low molecular weight heparin for 10 days. And then he restarted the treatment with Eliquis. Even though he complained of mild long-term hematuria after initiating the Eliquis. So this is something I try to explain to the patients. And here you can see, this is again and again, because I always follow the same strategy for en bloc enucleation with early apical release and sphincter mucosal preservation. But probably you notice that I'm moving the fiber a little bit slowlier. I'm a little bit less, let's say, pushy to advance. And I try to make sure that we get a solid first pass hemostasis. You see, so this is exactly the same as other cases where I, start by marking the white line and then entering in one side and the other side, and then developing the posterior aspect, and now incising, deepening the white line a little bit to get slightly better access. Here you see it doesn't matter if you cut a little bit on the adenoma. This opens like a book, you see, and it gives you a little bit better access to the proper plane. So even when you cut a little bit on the surface of the adenoma, you will notice that all the adenomatous tissue will be removed. And here, this is the development of the lateral line, mobilizing the apex and always trying to connect the line that we are generating on the side of the prostate to the previous existing posterior line, so that we have a continuous line that will help us guide ourselves during the procedure. You see, the movements are quite controlled and slowly, and I'm trying to make sure that I dissect and coagulate thoroughly in the first pass. And I think it is a good idea to have in mind that this patient needs a thorough hemostasis, and that's why I think the technique changes a little bit, and just a little tip to have in mind. So you see, we haven't seen any major trouble for keeping these patients with atrial fibrillation with a let's say reasonable low dose of heparin for 10 days, even 2 weeks sometimes. And of course we have significantly reduced the postoperative problems and return to the emergency room and like that. So I think we probably often, you know, overestimate the risk of having cardiac complications or emboli, and we maybe don't estimate enough how patients can bleed. Probably there I was having trouble with the leg of the patient. Sometimes the access is a little bit limited, so maybe I was moving the leg a little bit outside to try to get a little bit better access. You see, I have some limitation there, so I'm going to try to do little movements to try to get to the proper plane, so negotiate my access to the right plane. So often, you know, by liberating, you see, slowly from below, trying to advance a little bit towards the bladder neck, you can try to get some mobilization and then a little bit better access. But still, you see, it's a very, very relaxed technique, very slow motion movement of the endoscope. And here, you see, I'm now accessing a little bit better. I think that's a small nodule, apparently there, not really. And always trying to have these long lines that connect, you know, and that serve as a guide. The slow movement, the control of the endoscope, you know, to do slow motion movements will help you progress carefully, and there is no need to do, you know, brusque movements, or just keep moving slowly and be patient and try to make the most of the energy in the situation that you are at a certain moment. So always reflecting, you know, it's not a mechanical operation that you do without thinking. It's a constant concentration while you flow, you know, during the operation. Of course, we want to come to the apex and cut the apical attachment first. So before we continue the dissection of the lobe coming up towards 12 o'clock, we need to make sure that there's no attachment between the sphincter and the apex, so that we're not stretching the sphincter with our scope while we try to develop that plane, which was, I think, the main cause before for postoperative stress incontinence. Just dissecting, you know, this encircling maneuver that many people do, just going around carelessly, you know, without worrying at all and taking care of what's happening at the level of the sphincter while you do that. So by cutting the distal attachments, I think it gets much safer when you go up. And now you see, we should see the 12 o'clock fibers very nicely. That's the plane in one side. Let's mobilize a little bit more, even to have a better detachment of the anterior part. You know, when you detach the anterior part laterally like that, the apex falls, you know, and then you have a much better access at 12 o'clock to cut the 12 o'clock fibers. So it is a very progressive and careful approach. This is the 12 o'clock fibers on this side. So now we have a point of origin and we have a point of destination on the plane on the other side. So it's much easier to understand this anterior part. You see, that's the destination there. And now we have to work on the anterior line. Okay, we have posterior, we have two lateral lines, and we have now this anterior line that we need to work on, trying to make sure that we don't leave anterior adenoma, because sometimes if you leave anterior adenoma there, it might grow and become obstructive over time. So, but I feel that with this approach, we are quite safe, and at the same time, we are very aggressive at the 12 o'clock area. I always use full power near the sphincter. I never lower my settings, and I have to say we see a very, very low rate of postoperative stress incontinence, even using the higher power, which I think simplifies the procedure, because you don't have to ask the nurses helping you to change the power settings and play with the screen and like that. All these things make you lose time. And I think time is an important factor. You will see that we will do this enucleation in a very short time. And this is despite the slow and careful movement. And the trick, I think, is the continuous dissection. You know, the fact that the stopping time is really, really minimal, and that we are working continuously, you see, detaching the plane, following the lines, you know, just carrying this depth of dissection towards the bladder neck in a uniform manner. You know, we don't go one lobe all the way and then another lobe all the way. We go, let's say, circumferentially, getting closer and closer to the bladder neck, and following these lines. It's really a piece of cake. It's very easy to continue the dissection and judge the depth that you are finding in the prostatic capsule. Is it a capsular plane? Is the capsule white? Is the capsule smooth? Is it coherent with the depth that we had before? Is it smooth? You know, these are the characteristics of the capsular plane. And of course, is it not perforated, which means that, you know, often you have some doubts, and you can revisit the plane if you want. So here, for example, I was wondering, maybe we can go a little bit deeper there. You see, that looks like BPH tissue. So I'm going to deepen the plane a little bit. So slowly moving around, letting the energy do the spreading of the tissue and coagulating. And you see, I try to always build this line. You can revisit it. You can go a little bit deeper with your line and correct your plane. The same way that if you find that you're going deep in the plane too much, you start seeing, you know, peripheral zone anatomy, anatomical features, fat, I don't know, then you can correct as well. And the trick of this is to use the energy in a way that doesn't penetrate too much, so that you can actually stop before the perforation is too deep, thus making the procedure very safe. And you see that following these long lines, these long rhythmic lines that go from side to side, you know, of course, you can only see a little bit of the line in the image, but in your mind you have to have the idea of what line you're following. And I have to tell you, this is an paramount aspect of doing HoLEP, you know, knowing what line are you following, how the plane is going to change. So it's not only what you see on the image, it is also what you know about the anatomy of these lines and how you imagine that this line is going to go. Of course, the images you see give you confirmation of what you, let's say, already know. And so we have to use all the information that we can, what we see, what we know, and what we imagine. This is the three things that help us navigate around a capsular plane, you see. And also, when you are able to use the energy carefully like that, you can always probe, you can always try to see if there's a deeper, better plane, if you suspect that there might be, you know. So using a soft effect will help you, you know, exploring if the plane is correct. Because as we have discussed many times, staying in the beautiful plane is not always easy. Also, these energy sources that we are using nowadays tend to coagulate the tissue very well, so we don't see the beautiful plane anymore. And of course, if you find that there's could be a nodule, you can always dig and try to remove it, so that we perform a safe enucleation, which is also aggressive. I very often think about digital enucleation when you do an open. I'm not sure that the finger follows the beautiful plane all the time. Sometimes you find a deeper plane, and we didn't get to see the fossa with the level of detail that we see the fossa right now after digital enucleation of the prostate. So I think this idea of stopping to talk about the beautiful plane, and stopping to think that there's only one perfect plane that has to be found, you know, it's like the holy grail, right? It's very difficult to find. And, you know, change this concept towards the concept of a capsular plane. Capsular plane is sometimes the beautiful plane, sometimes a little bit deeper. It shouldn't be, let's say, it shouldn't mean that you're leaving adenomatous tissue. You know, mostly I think when you do enucleation, often you are in the beautiful plane, and or a little bit deeper, and you shouldn't be leaving BPH tissue. We have done a lot of intraoperative ultrasound, or, you know, right at the end of enucleation, you stick a transrectal ultrasound in the rectum of a patient, and you have a look at the quality of the fossa. And I have to tell you, the ultrasound, transrectal ultrasound, sees everything. You know, if there is a 1 millimeter rim of BPH tissue attached to the capsule, it will show very, very clearly. So we have learned over the years that this plane, what I call the capsular plane, is quite good, anatomically correct. But sometimes I had to agree that we might take a little bit deeper route and remove some of the peripheral zone with it. Okay, so now this is the entry into the bladder, more or less at the anterior part. I don't know if it's 12 o'clock exactly, but near 12 o'clock. And here also I'm going to be careful trying to coagulate the mucosal edge. As you know, holmium cuts by disruption, so when it cuts the mucosa, it doesn't always coagulate really well, and you could have mucosal vessels bleeding. That could be the cause for hematuria during morcellation, and also hematuria postoperatively. So there we are, trying to go around, you see, and that side of the capsule we saw some deeper regions, so we had time to correct. So we were starting to perforate, but we didn't follow through, you know, just corrected before the perforation was established. So this is how to you know, dissect the plane carefully to try to stay inside the peripheral zone. And, you know, sometimes prostates peel off very nicely, and sometimes it is quite difficult to follow, you know, a beautiful plane. And but still, if you're not seeing fat, you know, if you are seeing capsular plane characteristics, then you are in a good plane. And that's, I think, a simplification, because there was a tendency before to publish, let's say, the beautiful cases, the cherry-picked, the selected cases, where everything went really well. And then I think it was misleading for people who were trying to learn, because they said, okay, I cannot see this beautiful plane that I saw on the video, you know, because this is unfair. This is not, you know, that the every case reality. So most of the times, I mean, you might see the beautiful plane at some stage, but not around the whole adenoma all the time. I don't know. It's been a while. I don't know if I ever saw that, you know, a perfect plane all around. I think I did sometime, but so we have to progress, connecting the lines, you know, checking, and also, as we have discussed in previous videos, you have to use the fiber carefully, choosing the right or the best possible. I don't like to say the right, because when I say the right way to do things, you know, when you say that, it implies that there's only one good way, and there might be more than one, you know. And I think that when it comes to manipulating the fiber, there's probably, you know, different tissue effects that you can get depending on the working distance, the speed of movement, and also depending on where you target. You see, that showed a little bit of deepening in the capsule. So when we go back there, you see I'm going to keep closer to the adenoma to try not to deepen that already a little bit deep region. Also, we have to understand that the magnification that we use to see inside the prostate is very big. You know, the fiber is 0.5 millimeter. So maybe that opening we did on the you know, into the peripheral zone probably measures 2 millimeters or something like that. So it's not the end of the world. And of course, we didn't follow through to do a consistent perforation, and that's how you protect the patient from water extravasation and complications. Here we're coming near where the UO should be, so I think probably the next thing I will do, yeah, is to go in and check. We saw that the UO on the other side was quite close to the bladder neck, so that's some information that you have to keep in your mind. And so you see, sometimes we have the hint that we are in a nice anatomical plane. Sometimes we have no clue, but we have our lines, you know, and we follow our lines. And then we always check the quality of the tissue after the dissection. You know, if the capsule looks adenomatous, then you have to deepen, go back, deepen a little bit more. Often we will find nodules as well, and when you see something that looks like a nodule, you have to try to dig as well and try to remove the nodule. The same way when we did open prostatectomy, we would introduce the finger in the fossa at the end to check for nodules, you know, palpate these nodules and then try to take them out so we wouldn't leave adenomatous nodules inside. One detail I think is important is that we can see nodules apically, posteriorly, laterally, but I have to say I haven't seen nodules purely anteriorly. I think that's because the anterior fibromuscular stroma is probably tougher. I don't know why. We don't see a lot of nodules. And in one occasion I thought I saw a nodule and it was the pubis, bone, you know, one of these pubic tubercles protruding, let's say, making some deformation of the anterior capsule. So be careful up there. I think we are quite safe to explore these nodules laterally and posteriorly, but maybe if you see an anterior nodule near the bladder neck, be careful, because it might be the pubic tubercle, especially in patients with very large glands which occupy the whole pelvis. And just an idea to keep in a corner in your mind in case you face such situation. So there we are, trying to go around. You see, it's been 25 minutes and we are nearly finishing the enucleation, but I took my time and I didn't rush the dissection. So you shouldn't be rushing the procedures. I think the stress is not on running. The stress is more on continuity and structure and keeping the lines recognizable, because all these things, you know, when you have a very good line, you don't need to stop and see around, you know, just follow your line, and that will allow you to continue working with safety, even when you're not having a panoramic view of how the plane looks like, you know. And I think that's very interesting. That's how we can work continuously, even with limited visual information, because I mean, we know the anatomy, we know the lines, and that's the tilting of the prostate into the bladder, and that's the end of the 6 o'clock attachment near the bladder neck. So as you saw, 27 minutes, 28 minutes for enucleation of a mid-sized prostate. It's not too bad. And we were very careful with hemostasis, trying to provide the anticoagulated patient a better chance of having a tolerable, you know, postoperative course. So I know that some colleagues brag about doing anticoagulated patients in under full anticoagulation and like that, but I would advise caution. I've seen some very heavy bleedings, so don't blindly, you know, follow that advice, because I think maybe when you're a super experienced surgeon and your setup is, you know, very, very good, and your hospital is you know, properly equipped and like that, you have adventurous, you know, anesthetists and other people working with you, you're going to, you know, feel more safe to try things. But I would advise caution, as these are, you know, potentially high risk patients, and you know, it's good if you take all the possible precautions, and the risk of bleeding is there, and the risk of you know, cardiac problems, pulmonary embolism and like that is relatively low, especially if you use some form of anticoagulation. And that's my advice, to be cautious and to be careful. Here you see that I'm trying to do better hemostasis. So I'm going to be thorough before moving on to coagulation. And that's the fossa. Often in a patient who is not anticoagulated, you will, you know, tolerate a little bit of oozing of the fossa, because you know that the patient's coagulation system will take care of the final, you know, coagulation. I don't think it is necessary to burn the capsule all over, you know, very, very aggressively in every patient, because I don't know, maybe that also, you know, delivers a lot of energy to the capsule. So I usually can live with a little bit of oozing postoperatively. It causes minor, you know, hematuria the first hours, and then it normally stops very well. And but in these cases, I think we have to be thorough and before changing to morcellation. So 30 minutes, I think we have learned a lot and we have advanced a lot, and homium and enucleation is now a relatively fast procedure, irrespective of prostatic size. Of course, there's always extremes, but I would say that the majority of cases we do are taking under 1 hour, and very often, you know, 30, 45 minutes, 20 minutes, 15 minutes sometimes in the smaller glands. So it becomes, with experience, it becomes a very, very nice operation, devoid of drama, you know. It's very important to have a good team, and we have oversized our team. You know, I have 3 nurses working with me, helping during the procedure. One of the nurses helps the anesthetist at the beginning of the procedure, but then, of course, once the patient is anesthetized, she, you know, starts helping us as well to make sure that everything runs smoothly. When we have to change instruments, the change is very fast. Everybody in the operating room knows what to do and what to expect and how to react. So, for example, if morcellation is bloody, often they will have a resectoscope ready just in case I have to go back, you know, take out some clots and do additional hemostasis. So the idea is that you have a proactive team that can help you, that is present not only in the operating room but also in the operation itself. You know, they know what's happening. Their attention is placed on the operation, so that, for example, they check that there's water enough during morcellation. Normally, you have your eyes stuck to the screen during morcellation, and I think it's important that they know, you know, that the whole responsibility of the operation doesn't fall on your shoulders, you know, because you have to control too many things. I mean, you have to rely on your team to control all these things that are not just the operation, you know, everything that happens around, and you have to trust them, because you are operating and you cannot control all the external factors against nurses that are, you know, talking about their things while you operate and things like that. You need a very focused team that wants to make sure that the operation is uneventful and everything is ready and fast. And then it is a great pleasure to operate in such an environment. I know that for many people it's difficult because they have changing teams and like that. And I say, in these cases, you need to do a briefing before the operation, explain everybody what is their role, you know, and try to control all the details. And when I have to do a live operation, for example, sometimes we are lucky, we go to departments who already do a lot of enucleation, and they know their job very well. But otherwise, you need to spend a good deal of time explaining everything so that the nurses know their job and what to expect and what to do and when to do it, and then, of course, the operating room is a much safer environment for the patient. This is morcellation. You see, the good visibility allows you to bring the piece inside the fossa, or just keep it there at the bladder neck where, this is already inside. You see, the piece will clash with the walls of the fossa, and will not escape, so it becomes very, very efficient and very nice. That's the sphincter mucosa. Bye bye then, see you next time.